doctors. On behalf of Microlabs, I welcome all the doctors who have joined us from across the country to this Pride program. And today we have some of the eminent panel members here to discuss with us on some of the interesting aspects of diabetes management. So first, let me introduce Dr. Ashok Kumar Das, who is going to moderate the program with us. We thank you very much, first of all, sir, for agreeing to moderate the program for us. And we also have Dr. Shubhankar Chaudhary from city of Kolkata. We welcome you, sir. We are honored to have you today with us. And we also have Dr. Shashank Joshi from the city of Mumbai. Welcome, sir. Thank you very much for joining us. And we also have Dr. Jeevan Joseph from God's own country from the city of Kottayam. Welcome, sir. Thank you very much for joining us. Now it's my pleasure to introduce Dr. Ashok Kumar Das, who needs no introduction to the medical fraternity. So Dr. Das is presently the Professor of Medicine and Head of Endocrinology, PIMS. He was former Senior Professor of Medicine and Endocrinology, Head of Department of Endocrinology, Dean and Medical Superintendent of JIPMER Pondicherry. And he has taught medical undergraduates and PG students in diabetology for more than 33 years. And he has also served Government of India on various positions. Thank you very much, sir, for joining us. I request you to take us through the program, sir. Thank you, sir.
My dear and esteemed colleagues, those who have joined all over the country, I welcome you on behalf of all of us to this very unique program. Dear friends, the program is unique because we have amidst us the expert of the experts who have contributed immensely in the field of diabetes and endocrinology. Dear friend, we have amidst us Professor Dr. Shubhankar Chaudhary, who is the MD DM, and he has given hundreds of DM to various students in his career, which he just came out of the medical college about a month or two back. He is currently the Director, Diabetes and Endocrinology at the Medica Super Specialty Hospital, Calcutta. He had been, I don't believe in farmer and eggs. That's what Dr. Moses Sasang used to tell me. No farmer. He is the professor and head now doing different type of work from the Department of Endocrinology from the PGMER and SSKM Hospital, Kolkata. He had an annual intake of 21 students. I have 7 students, 21 students anytime. Now it has further increased. He is the past president of the ESI, Endocrinology of India, and did a lot of good work during his time. He is editor-in-chief of IJEM, the Indian Journal of the Endocrinology and Metabolism, one of the best journals in the country. He is the member of the Subject Expert Committee, those who give approval for the drugs, the CDSCO, Government of India. He is the chairman of the RSTI West Bengal chapter and president of the Endocrine Society of Bengal. And he had been the founder patron of the SAFIS, the South Asian Federation of Endocrinologists. The next, I would like to, Shubhankar, welcome you with folded hands. Thank you. Welcome.
Thank you very much.
We'll go up.
It's a wonderful opportunity.
Thank you. We'll go only up to 8 o'clock. It's just free. And, you know, we do not have any meeting amongst ourselves, but we had some discussion regarding what we should discuss. So it will be very interesting. We have Professor Shashank R. Joshi, MD, DM. He's a fellow of American College of Physicians, fellow of American College of Endocrinology and FRCP. And he is the consultant endocrinologist from the city of Mumbai. He is the founder, vice president of the PCOS Society, which is new and which is a great need for the country. There is affiliation to Lilapati Hospitals and HNRFH Joslin Clinic, a publication honors 100 plus publications and about 100 books he has authored. And he is ranked in the top 0.5% in the field of general and internal medicine across 106,000 authors globally. He has the unique distinction of getting the Padam Shri from the Government of India in 2014. He's the International Chairman of the Year Award in 2012 from the American College of Endocrinology. He is President, Indian Thyroid Society, past President of the International College of Nutrition, past President of the ESI as Shubhankar, past President of the API, and also past editor of the JAPI, past Dean of the Indian College of Physicians, past President of RSTI, and the past India Chapter Chair, American Association for the Clinical Endocrinology. and the immediate past chair of the IDF Southeast Asia, which has his contribution having looming large. Sasank, hearty welcome to you. Then we have a very young, our own Dr. Jiban. Dr. Jiban is the Jiban Joseph is the director and consultant of the Jiban's Diabetes Endocrine Clinic Center from the Bimla Hospital from Kottayam. He is MBBS. He had got his membership here, first of Edinburgh, and the specialist training and certification from the UK in endocrinology, director endocrinologist at the Jiban Diabetes Endocrine Center, Kottayam, formerly consultant endocrinologist at Newcastle in United Kingdom. He has got many awards, few I have cited here. NHS Clinical Excellence Award, UK, gold medal in the MD examination in Chennai, India, and publication and lot of research experience in the type 1 diabetes. Dear friends, we are here today to discuss regarding the combination therapy, and to discuss about the various combinations that in the armamentarium, which you should use very judiciously, very enthusiastically for the patient. I'll just say one sentence before I start the interaction. I must tell you my questions is to collect questions from you. So I request the entire audience to kindly post your questions, Subhankar had just mentioned, in the chat box. And I assure you we'll take up as many questions, maybe all the questions one by one. If some questions left, we'll reply by email because we'll not go beyond 8-5 1 hour program. Now, the number two is I must also tell you that the combination therapy is the most important contemporary challenge to treat type 2 diabetes in our country. Why I say so? It will be evident when you listen to the introductory remarks, which I will ask Sasank to give. Sasank, what is the state of our nation as far as diabetes control is concerned?
So, Professor Das, I thank you for this opportunity. At the onset, I want to thank Microlabs
Good.
and this Pride initiative, particularly Sheshgiri and his team. And it's a pleasure and delight to see Shubhankar Dada and my good friend Jeevan. We are 8 billion people on planet Earth. 1.46 billion people live in India. And worldwide, around half a billion people are living with diabetes. Another half a billion plus people are living with pre-diabetes. And if you see the ICMR in-depth study, which you are an author and Dada is author and I'm an author, currently 101 million people are living with diabetes and around 236 million people are living with pre-diabetes. So if you see worldwide, 1 in 8 people are living with diabetes or pre-diabetes. And the control is the key. Now, control has 3 components, if you ask me. But today our focus is glucose control. So, you need A, B, C, D, E, F for diabetes. A for A1C, B for blood pressure, C for LDL cholesterol, D for diet, E for exercise, F for feet. But the A1C control, if you're looking at non-pregnant adults below 7%, more than 90% of people living with diabetes are not achieving their target. Okay, and this is a worldwide phenomenon. So India is no exception. So a mean average A1C from different studies and data sets on an average is between 8.5 and 9. And in the first decade of a diabetic's life, particularly our focus of discussion today, I presume, is type 2 diabetes, because type 1 diabetes or gestational diabetes or secondary diabetes, the treatment is replacement of insulin. But type 2 diabetes, which is 97%, 99% of the garden variety diabetes, which we see, is heterogeneous, has a lot of clusters, but the A1C is between 8.5 and 9. That's the status of control. And in the first decade, we need to hit hard, hit early. And therefore, the control of diabetes, even in the best of centers, remains poor. And that's linked to compliance, that links to lack of adherence, that's linked to multitude of factors, including continuity of care. So the multiple C's which are involved in control include continuity of care, compliance, cost, and of course, convenience. And all these lead to a poor control. And this poor control directly is translated into outcomes. And the next C comes up, which is complications. See, we should have a goal of having a diabetes-free world and a diabetes-free India. But that That is a utopian goal. Our current goal should be having a complication-free world of people living with diabetes. And in that goal, our control is very poor. And I would say a ballpark figure of 8.5 of an A1C average is seen in garden variety type 2 diabetes, because it's impossible for 1,000 endocrinologists in the country or 5,000 diabetes experts in the country to treat everybody. So the mass majority of people living with diabetes are actually going to primary care. And therefore, it's very important to understand one concept: hit hard, hit early. And for a majority of the cases, we are aiming at an A1C below 7%. Of course, we would love to keep it at 6.5. And, there are relaxations up to 7.5. But between 6.5 to 7.5, a mass majority of 80% of people are not in control. So 4 out of 5 people living with diabetes in India are not in control. That would be the state of our nation. So this is a poor state of control.
I think, Sasank, in your own inimitable style, you have given the message, which is loud and clear. We have large number of diabetes. The problem is how do we control them? Because the control is too bad, which resulted in lot of metabolic complications, which came out in the paper you referred to, that we all published together along with Mohan and Anjana. That is the paper that said that the metabolic complications, be it obesity, be it dyslipidemia, be it hypertension, is running high. At the same time, the pre-diabetes, as you rightly said, even a bigger problem than the diabetes, which also needs control. Now, I think before I come to Sasank again, Subhankarda, I have a free question for you. Subhankarda, I would like to ask you, is combination therapy a way out? And before that, I love to introduce a concept which all of you very well aware, that the early control matters. In fact, the Chicago School of Medicine paper, which came in diabetes care, said first year control matters. Following that, one more paper has come this year, which we have published in the micro book, which will release in the API. Shubhankata, you have also written in that book, Sasank has written. We have said even the first 6 months control, not we have said, we have reviewed the literature, first 6 month control matters. Therefore, the early, you call it aggressive, you call it intensive. I have called it intensive. Control is paramount. Now, for that, Subhankarda, is combination a way out?
Yeah. So thank you once again for having me on this panel. Uh, Now, we are all aware of the relatively poor glucose control that we have across the globe, especially in our country. And we do know that there is something, there's something called efficacy of a drug, and there is another thing which is effectiveness. And there is a gap between the two. And this gap, to a large extent, is related to compliance. And here, I think combination treatment could be useful, especially if you have your A1Cs way off the target. None of the oral agents, and usually we do start with oral agents. Sometimes, of course, we take recourse to insulin at the very beginning. None of the oral agents, apart from metformin, possibly sulfonylurea, can achieve an A1C lowering on its own by more than 1% point, mostly between 0.5 and 1%. So in order to achieve what Dr. Shashank has just said, that A1Cs are around 8.5%, we need to bring them down to at least 7, if not even lower. Earlier on, maybe it's better to get it down even lower than 7% in most individuals without other complications. We have no other option but to use combination drugs. This could be 2 drugs taken separately, or it could be fixed dose combination. So I think there is a great need across the country, across the globe, and more so in our country.
Yeah, I think, Subhankarda, I'll combine one more question here. We know the multiple defects of diabetes. You have written about it, Sasank written about it. from ominous octet to dirty dozen or villain 11, whatever you call it, the defects are at least 8 to 11 to 12. A single drug versus combination therapy. How do they address this multiple defects in type 2 diabetes?
Yes, I would still like to believe uh, what maybe you and I taught and what taught in our medical MBBS days. The basic issues are still related to insulin resistance and beta cell dysfunction. Those are the most important, would explain, I think, 85% of the pathogenetic issues in type 2 diabetes. So we need to at least address two different aspects, insulin resistance and beta cell dysfunction, if at all possible. But of course, now we understand there are other issues, including very important role of the kidneys and also of the intestine, of the liver, of the brain, and all that. So yes, definitely, it'll make sense when we talk of combination of drugs. Using two sulfonylureas together clearly doesn't make what sense. Using two DPP-4 inhibitors doesn't make sense. We need to use drugs that have complementary mechanisms of action and which will address different pathophysiological effects of type 2 diabetes.
Thank you, Subankar. Very great answer. Dr. Jiban Joseph, I will ask you a very simple question. There are people, there are countries, there are nations which advocate no FDC but free combination of individual drugs. The countries like UK, like say country next door, the Sri Lanka, they do not have FDC. I like to have a very small comment from you regarding the FDCs, say DAPA and MET together, or combining MET and then giving DAPA as a separate tablet.
Yeah. So thank you very much for having me on this very august panel. I think I would, kind of begin by saying that even in countries which have got very high access to healthcare, only 39 to 40% of patients actually have good adherence. And it's very clear from lots of research that we already have that almost every 10% increase in adherence leads to a 0.1% drop in HbA1c. So there's no question that treatment adherence actually matters. And that's where FDCs, probably in the Indian scenario, are a boon rather than a bane, because we do struggle with compliance and adherence, patients being lost to follow up, etc., etc. So it's certainly helpful to clinicians in the Indian setup to have fixed drug FDCs, especially if they are rational and synergistic, as Shubhankar sir said, and addresses almost 6 of the 8 the pathophysiological basis of the octet. And we also know that this combination also lowers glycemic variability and achieves HbA1cs faster. So I think considering all of that, I think there is a role for this, and a role very strongly in the Indian setting.
Good. I think it's a great answer. Now we have discussed all the aspects. We'll now ask Sasank a very deep question. Sasank, can you give us that how do we address these multiple defects in the appropriate FDC? Government of India has cut down 3. 2 is probably the most optimal combination. We are accustomed to it for a long time. What's your comment on the addressing the multiple defects by the fixed drug combination? And do you think that the answer, as all have explained so far, is the FDCs? What's your comment on that, Sasank?
So let us look at history.
Yes.
Historically, type 2 diabetes had 2 defects.
Yeah, that's Subhankar that said.
Insulin resistance and insulin deficiency. So historically, we had a sulfonylurea with a metformin. That is how the therapy started. Okay, then the birth of alpha glucosidase occurred, which were basically a prandial regulator with carbohydrate blocking. That is the third therapy option which came in. But Professor DiFranzo, 25 years back, in his elegant Banting lecture, told us that it is an octet. So fundamentally, when you are addressing the octet, the beta cells make insulin, which work on different metabolic organs. So the first defect is that we have to stimulate and synthesize insulin appropriately without causing hypoglycemia. And that is addressed best by the gliptins. Gliptins switch on the beta cells and secrete insulin only when the glucose is high, but do not switch on the beta cells when the glucose is normal. So does not cause hypoglycemia. The second thing is inside the pancreas or the islets of Langerhans, there is alpha cells. So what happens is that they are switching on the beta cells, but they are switching off, the gliptins are also switching off the alpha cells, which are actually secreting glucagon and which is impacting the hepatic glucose output. Because fundamentally the role of glucagon is to cause hepatic glucose diarrhea. So the second defect is the alpha cells. So what is a gliptin doing? It is switching on the beta cell. It is switching off the alpha cell. Thereby, physiologically, it is increasing insulin when glucose is high, and it is not increasing insulin when glucose is normal. So no hypoglycemia. Number two, it is switching off the alpha cell. So glucagon is not secreted, the second defect. The third is the indirect effect of this is that the liver, which is where metformin works, it is basically preventing the hepatic glucose diarrhea. See, 24/7, the largest metabolic organ of our body is the liver. Even when we are sleeping, it is the liver which is giving us and converting from glycogen to glucose. So whatever is the fasting which is reflected next day morning is an impact of the hepatic glucose output. So the third defect is addressed by metformin and indirectly by gliptin is the hepatic glucose output or the liver effect. So this is the third defect. The fourth organ is the muscle. Muscle has glucose GLUT4 receptors. The fifth organ is the fat. The sixth is the intestine, which makes incretins. The seventh is basically the kidney, which has the SGLT2 receptors. And the eighth is the brain. Now, when we are looking at it from a pathophysiological standpoint, the gliptins, the metformin, and the SGLT2 inhibitors have occupied this space and addressed 7 out of the 8 defects, Professor Das, fundamentally, except the brain. And in the brain, we had a quick release bromocriptine, but that really never took off. Okay, except that the all other 7 defects are pathophysiologically addressed by the 3 major evidence-based drugs. Metformin, which is the gold standard, more than 90, 100 years old now. If you see the first paper of metformin is 1922, we are in 2023. It is 101 years old, but commercially got available only after the World War because it was a French compound, so English literature is poor on it. Okay, that is number one. Number two is a drug called gliptins, which don't cause hypoglycemia, don't cause weight gain, and are a no-brainer. By and large, compete with placebo for adverse events. And the third, which go one step ahead of a gliptin and metformin, are the SGLT2 inhibitors. Fundamentally, the advantage of SGLT2 inhibitors is that they are able to not only lower glucose without hypoglycemia, but have some degree of weight loss, but have compelling impact on cardiovascular outcomes, compelling impacts on renal outcomes. So both nephrologists and cardiologists are competing, saying that they are their drugs. So fundamentally, when you are looking at these 3 classes of agents have occupied the predominant space today in the oral space of the 7 out of 8 defects which Professor Ralph DiFranzo described. Fantastic. I hope I have been clear in my explanation.
We'll make it more clear as we go across, Shashank. Now, Subhankar, I have to ask a question. That are Asian Indians likely to have more profound benefit with SGLT2 inhibitors? If so, why?
Right. Maybe let us also refer to the DPP4 inhibitors.
Yeah, they are also likely to be more beneficial.
Yeah, yes, it is suggested that Asian Indians possibly benefit more because they generally overexpress DPP4. So inhibiting that gives you a better advantage. So A1C lowering of 0.5 to 0.6% that we learn from Western literature may actually translate into something closer to 1% for Asian Indians. So those may be more effective agents as well for us. Now, as far as the SGLT2 inhibitors, yes, there's also evidence that they are probably they have better effect in Asian Indians. The exact reason I am not sure of, but part of it could be because they are known to reduce total body fat, they are known to reduce visceral fat, and we are known to harbor a lot of this abdominal fat. And so those are effective agents in reducing this visceral fat, the harmful effects. So that may be one reason. Actually, this is in a lighter vein. The Vortis CV study with ertugliflozin failed to show significant improvement in many parameters. And it is suggested that that was because Indians were not included in the trial. And all the others, if you look at the subgroups, even the EMPA-REG outcome, if you look only at the European descent people, you do not see significant advantage with empagliflozin. But only if you take also the Asians, the Indians in it, then only you see the advantage. So there's something going on. Maybe partly we do understand, partly we do not. But there is evidence out there for us to see that we benefit more out of those agents.
Fine. I think, Subhangata, I have a very focused question that audience also wants to know. You know, various guidelines today are advocating the use of SGLT2 inhibitor either at the onset or just after the metformin, number a second term. And, this has been recommended different guidelines. Recently, one more paper appeared, also said about the same thing, that SGLT2 can be used in the beginning, or if not beginning, at the second. Now, can you give us some clear sight? Because one of the discussion today is the combination of metformin plus SGLT2. In contradistinction to many other combinations, which we'll also discuss, but this is the recommendation today, SGLT2 plus metformin. Now, Sumakarta, what does the various guidelines say and how do you view it?
Right. I must say that we have learned over the years that while glucose control is important, as Dr. Shashank has very rightly pointed out, and you've also mentioned, not only do we need intensive, good glucose control, we also need it early enough. But beyond that, we now understand that the treatment, the management of type 2 diabetes is not just about glucose control. It's eventually to prevent those complications. And there could be agents which may not be very effective in lowering the glucose levels, but can protect the organs. And SGLT2 inhibitors fall precisely in that category of drugs. So they are used and advocated across guidelines, whether we talk of the ADA, we talk of the AACE, or our very own RSSDI guidelines. All of them would suggest that if the person with type 2 diabetes has either established atherosclerotic cardiovascular disease or has multiple risk factors for the same, or have chronic kidney disease, and we understand today that chronic kidney disease could mean either one or both of albuminuria and raised creatinine or reduced EGFR, then SGLT2 inhibitors would be a preferred class of drugs. GLP-1 receptor analogs are also indicated. I must say, in our country, SGLT2 inhibitors are much more convenient because we have the luxury of having many of these drugs now off patent and at a much lower price than elsewhere in the world. So many more patients can afford quality SGLT2 inhibitors at a lower cost. So yes, because of organ protection, I mean, proven evidence of organ protection, especially the heart and the kidney, these are now being recommended across different guidelines and even irrespective of glucose control. In the past, it used to be use first this, and then if the A1C is not controlled, then you go on to another agent. Now you can use them if you have those concerns about organ protection, even if the A1C is normal.
Yeah, I think great answer. I think I want to ask one question to Jivan. Jivan, we have uh, both the combinations, DAPA plus MET. We have DAPA plus sulfonylurea. Now, what is your take? How will you position the use of these drugs in the various groups of the patients? That is the crux of the issue for this meeting today. So I'm starting with you. How would you view the use of DAPA plus MET?
So,
Then it has,
before, yeah, so sorry, before Jeevan answers, I'm sure he will provide the answer. I'm just drawing your attention to the fact that we have a question in the chat box. So, Dr.
yeah,
Das, so you can take it up
yeah,
after Jeevan answers. Yes.
yeah. I have got
Okay.
that question which
Yeah.
RX7 has posted already. I'll take up after this. Now,
Yeah.
now,
Sure.
yeah. How do you think that DAPA plus metformin has some advantage over DAPA? I mean, metformin plus SU as the initial therapy in type 2 diabetes?
Yeah, so I think in the context of all that has already been elucidated, I think it's extremely clear that the combination of metformin with dapagliflozin does have significant advantages because it crosses the glucocentric model and goes towards addressing some of the hard um, clinical endpoints that we require, as opposed to just focusing on the glycemic control itself. So if you use a combination of dapagliflozin with metformin, in addition to the pathophysiological basis powering it, you also have benefits in terms of the heart failure risks. Patients at high risk of ASCVD are benefited. Patients have increased and better renal outcomes. And there's also emerging evidence of um, a beneficial effect on non-alcoholic fatty liver disease. You have reduced risk of hypoglycemia. You have increased weight loss. And so you have everything that you require in terms of what you would want in terms of hard clinical endpoints and multiple benefits for a very cost-effective price. And certainly, if you look at it from that angle, there must be very strong contraindications for not using this combination, and we should be actually looking for reasons to use the combination rather than the traditional combinations.
Right. But Jivan, there's a very interesting question in the chat box. Dr. Sheikh Teruddin is the person who has asked this very intelligent question. I mean, very simple. Blood glucose levels do not come down as rapidly or as much I'm adding with glimepiride. So with in contradistinction to SGLT2. SGLT2 0.6, 0.8, maximum 1. And the glimepiride is more powerful. So he wants to say that in case of where it is not indicated, like nephropathy, where the hypoglycemia can occur with glimepiride, why don't you think that we should go for sulfonylurea than for the SGLT2 as the initial combination?
Yeah, so again, I think it's a good question. And we do want to be able to demonstrate efficacy very quickly. But if you look at trials which have compared glimepiride to, say, linagliptin and glimepiride to SGLT2s, we see that over the longer period of time, there is not much to pick and choose between these. If the SGLT2s are going to be effective from the glycemic point of view, for which you need an EGFR of greater than 45. There might be reasons why you want to quickly get optimized things. And in which case you could even consider things like insulin as well. But otherwise, if you look at the longer term scenario and the fact that with diabetes, we are running a marathon rather than a sprint, I think this combination still makes sense and makes sense to probably use it early.
Yeah, maybe Jivan also when we combine SGLT2, there are some studies which have shown even 1 and little above 1 H1C reduction. Even the individual studies showed zero point 0.6 to zero point 0.8, and also the huge benefit. And as Subankar also hinted at, today diabetes care also has become obesity centric. Am I correct? We had a pure 3-day discussion on the. I think you were there, Sumagarda. You came for that meeting by Mathur, Sandeep Mathur. You remember on the
I was
obesity?
there, yeah.
Yeah. So obesity as the central aspect of diabetes management, and there's no comparison of DAPA in the weight reduction compared to sulfonylurea.
So,
And
Dr. Das, can I make a comment here?
yeah, I'm coming to you. Next question
No,
entirely.
no, no. I'm just looking at what Jeevan was saying. I want to
Yeah,
dilate that a little bit.
please.
See,
Sasha,
unfortunately,
I'll just add one question to
no,
it.
no, no,
Sasha,
no. You can ask
I'll,
me the question later. This is related to this point of
okay,
glimepiride. See,
please.
we have got wedded with a concept that we want a very rapid glucose lowering of fasting and prandial without looking at the A1C. Because traditionally, when we were in medical schools, we used to only look at fasting and postprandial glucose. And therefore, we wanted quick results overnight. But the real glucose control is in the A1C control. We want both.
Yeah,
And
absolutely.
therefore, it is important to understand and contextualize it from that standpoint. Now you can ask the question.
Yeah, the question is exactly that. Now, there are some issues that some data has suggested that DAPA plus MET having distinct superiority over SU plus MET as the initial therapy. Sasang, your take on that?
So I think this is two things. See, SU-MET, what are the challenges with SU-MET? Metformin will always remain, but SU has some degree of hypoglycemia which DAPA doesn't have. SU has some degree of weight gain which DAPA doesn't have. And the main thing why SUs are waning out, though they may be very useful in the first decade of a diabetic's life, is they don't have durability. See, there is a durability and coefficient of failure. So in the good old days, if you look at Goodman-Gilman pharmacology, there used to be a coefficient of failure for a chloropropamide, for a glibenclamide, which we don't use anymore, tolbutamide, for a glimepiride, for a gliclazide, for a glipizide, and for a metformin and a fenformin. Now, if you look at it from that standpoint, the SUs are maybe very good for rapid glucose control, but over period of 5 year, 10 year, 15 year, they do not have sustainability or durability. And they do not have cardiovascular positive or renal positive data. Their data at best is neutral. Okay. So therefore, when you compare them head to head, a DAPA MET versus say a SU MET, clearly the superiority is for a DAPA MET for two reasons. Number one, no hypoglycemia. Number two, no weight gain, maybe some weight loss. Number three, positive cardio-renal outcomes. So therefore, and number four, long-term sustainability or durability.
I think that's what.
So when you look at it from a holistic standpoint,
Yeah, I think.
clearly the pharmaceutical and clinical advantages are reasonably compelling and overwhelming to make them as a agent of choice over a traditional SU metformin. And therefore, worldwide, if you see North of America, if you see Europe and rest of the world, this combination is on the wane.
Thank you. I think Sasank, very significant answer. It also answers the question Dr. R. Sasikiran has posted. Sasank, the Sasikiran exactly has asked the same question that, we know that the drug of choice, if the fasting sugar is between, say, I'll may modify it between 150 and 180, it is glimepiride because it's very effective and brings it down. He says that what is the other drug that can use? I mean, he's referring to probably a SGLT2. If the fasting sugar is, if the blood sugar levels may not be fasting alone, is between 150 and 180, are the drugs that you are suggesting now are as effective?
So first thing is glucose is only one metric in
Yeah,
my overall diabetes management.
correct.
And I'm appreciating his question because you have to look at the age, the duration of diabetes, the associated comorbidities, the renal, the liver, the cardiac comorbidities or complications the patient has, the amount of vascular complications there. the past history of vascular episodes. Is the person having an associated life-threatening disease or not? So I think the glucose control is not centric only with a tunnel vision of glucocentricity, which Jivan very rightly said that we are moving beyond a glucocentric tunnel of a glucose control to a more holistic, comprehensive care of diabetes in a continuum of care. And therefore, yes, SGLT2 inhibitors are there, but sometimes you need to tweak for individualized or precision approach. Because, there will be situations where, for example, somebody has a pyelonephritis, the same individual. Then my choice may not be the SGLT2 inhibitor. But in the absence of a pyelonephritis,
I
it
got you.
doesn't cause UTI. So you have to be very clear in individualization of therapy. And I think SGLT2 with metformin are becoming agents of choice, and gliptins and metformin are becoming agents of choice, both in primary care, secondary care, and tertiary care, both in diabetes practitioners and people who are in allied health, like cardiology and nephrology. So I think it is pretty compelling and straightforward in this area. And therefore, even for 150, 180, I think it is reasonable to use an SGLT2 inhibitor with a metformin combination.
I think we had a good discussion about it. We had discussed all the aspects. I leave it to the audience to assimilate it. It's about the multicentric approach, about the weight-centric approach. Combining the two drugs, the drop in the blood glucose is much higher, and negating the effect of the fear of hypo or even weight gain. So all this stands tall when we use this combination of DAPA plus MET, and we must move with time. I think that's one of the what I like to say, Subhankarda, Jiban, Sasang. We must move with time. I know now the drug that has come, which has given a lot of benefits. Somebody has written recently, Dr. Sashi Kiran. Yeah, he has written that not to use a DAPA, not DAPA, not to use a SGLT2 is possibly not acceptable. He says this drug has become AAA. It is appropriate, it is affordable, it is available, and what is accessible. So therefore, I think, Sashi, we have got the answer to your question. Now I'll come to the other part of the story. Now, what is the take on the use of DAPA plus a gliptin? And the gliptin I'm suggesting here is the combination that Micro has today, which is very appropriate. I mean, we'll discuss that. DAPA plus sitagliptin. You know, DAPA plus sitagliptin has stood out tall today. And, we can discuss about which are the gliptins which are undergone clinical trial, which has cardiovascular CBOT trial data. And, and what's the comment on the DAPA plus sita combination? I'll go to Jiban, Subhankarta, and Sasank. Very brief comment, because we have got another 20 plus 5, 25, 30, 25 minutes more.
Yeah, so I think brief comments about the DAPA plus SITA combination is that they're both top of the line drugs, both in terms of the breadth of experience that we have and also the clinical trial data and real world evidence data. Sitagliptin obviously has the TCOS trial to back it up, and dapagliflozin has the DAPA CKD trial, the DAPA HF trials, and also the trial showing reduction in the ASCVD risks. So there's no doubt that in terms of addressing beyond glycemic control, this combination is tried, tested, and proven. As previously outlined, it does give you good glycemic control because of it being a combination, and you can achieve HbA1cs faster with no risk of hypoglycemia and less weight gain. So I think there's no reason not to use it. And my own take on this is that there should be contraindications not to use the combination along with the gold standard of metformin, if that is also indicated.
Yeah, I think I remember Sasank and Subhankarda, and of course Jivan. I remember Professor R.D. Lele. R.D. Lele, I mean, when before the other gliptins were introduced, cheaper gliptins came to market. I'm referring to gliptin. He spoke to me while I was in the ministry that, the Africans prepared and manufactured the anti-HIV drugs without a license, and the whole world accepted it. He said that gliptins are so good, and gliptins are also good for India because, as we just now discussed, it has a better effect in Indians. He said, if the government is not willing to bring down the price, not going to do something about the patent, Why not we start manufacturing gliptins? I'm just telling it by the by to emphasize that gliptins are another wonderful drug in the armamentarium. And it is rightly said by Sasank, Subhankarda, and also by Jiban that it is for Indians is a better drug. And gliptinize India was one of the call given some time back. Gliptinize India. So, what is the take on the? We have heard Jiban. We'll hear it from the Subhankarda for the SGLT2 and gliptin combination. I will ask Sasank the most vital question: how to position differentially the SGLT2 plus MET and SGLT2 plus gliptin. Subhankarda, next Sasank.
Right. So about this combination, beyond what has already been captured by Jivan, I would suggest I'll sort of extend the concept that you've been just propounding, the Make in India concept. So we may not be having a sitagliptin dapagliflozin combination elsewhere in the West, but so what? These are the ones which have come off patent earlier in our country, and they are excellent partners to be combined to give safe and effective combination. So we should embrace that and try and make the best use of it in the interest of our patients. That's my short answer.
Yeah, I think absolutely correct. This is the only gliptin which has undergone the CBOT trial, and it has been shown to be at least neutral compared to saxagliptin others, and therefore it can be there. We also know the cutoff points for the kidney failure and all that, so it can be there. Now I will ask Sasank to tell us that that DAPA and SITA are the most evidence-based SGLT2 gliptin combination. And how will you station it? How will you position it? How will you give it to the to all of us who are practicing diabetes in our armamentarium? Sasank?
So, Professor Das, beyond with what Professor Shubhankar Chaudhary ji and Jivan ji said, there is one important pharmaceutical point. When you combine a gliptin with a SGLT2 inhibitor, okay, the only rate limiting step of easy use of SGLT2 inhibitors is genital mycotic infections.
Absolutely.
And the DPP4 enzyme in the fungus is inhibited by DPP4. So there is data which was picked up in the phase 3 registration trial of EMPA and linagliptin by Professor DiFranzo and multiple other authors when it went through registration in United States for the US FDA. And from that, it was correlated that when you combine a gliptin and SGLT2 de novo in the beginning, then the incidence of genital mycotic infection is less. Therefore, you have the best evidence-based gliptin, sitagliptin, best evidence-based gliptin, dapagliflozin, and when you are combining either, the likelihood of genital mycotic infections, at least based on retrospective data, is going to be lesser, which is a major rate limiting. So there is some biological basis to it. And of course, we need to be pharmacovigilant. But I think this is an important and interesting observation point all of us need to highlight beyond what Professor Chaudhary and Professor Joseph told us. So this is one. Second
Good
is
at
that
this point.
that you see, Sita Dapa are both off patent. Both of them are now in the generic space. So they are available, affordable, accessible, and they have, you know, neutral to positive data from an outcome standpoint of cardiorenal. They have reasonable data that there is no hypoglycemia. At best, they are weight neutral or weight can cause weight loss. So when you have so many advantages, I think it is important to make a armamentarium change in way we think. But having said all this, Professor Das, I think we need to still individualize. One size doesn't fit all in today's type 2 diabetes care. We have clusters, we have, various clusters of type 2 diabetes, and one size doesn't fit all. So individualization is the key. And a large proportion of the Asian Indian phenotype cluster uh, will see a fit in this combo. But as I said, one size doesn't fit all. We are four individuals. All four of us have different BMIs. All four of us have a different culture at home. All four of us eat different foods, have a different lifestyle. And if all four of us have type 2 diabetes, the approach is not going to be the same. So I think the key to all the people who are listening to this is that beyond using these combinations which are affordable and accessible, individualization is the key. So rather than saying A is good and B is bad, I think there is a place for each of these combos for that particular phenotype. And therefore, it's important that when we see a patient or a person living with diabetes in our clinic or office or in the hospital, I think it's important to ensure that we are able to put them into a cluster and then sort of mix and match treatment opportunities and options for that particular cluster.
Fine. I think it's a great answer. And it rightly says, double drug combinations galore. And one has to pick up the drug what one exactly needs, depending on the H1C level and your target, how much it is above the target. And before I'll make it clarified further. But Sasank, thank you very much for this very, very, very significant answer. Thank you, Subhankar. Thank you, Jiban. Now I've got one question to ask. You know, just to remind, before that, there's a question very interesting. Now this is a question which has been asked by Dr. Santosh, and then before that by Dr. Shorup Pal. Santosh wants to know, I want very brief answer, please. Why SGLT2 inhibitors are not initiated below GFR 20, and uh, and uh, and uh, uh, and and why is not 20? But if SGLT2 was continuing, uh, if GFR is falling and going to below 20 GFR, I think what is meant by that, till what level of eGFR you can give SGLT2? Subhankar, like to take this question. I think your mic, I think you're not audible. I think Sasankta,
Yeah,
you're not
sure.
audible.
Yeah, no. Sorry.
Yeah.
Yeah. So we do understand that SGLT2 inhibitors for their glycemic efficacy rely on the glucose excretion through the kidneys. And for that, you need a certain amount of functioning renal function. So if you go beyond very low levels of renal function, then the kidneys cannot put out enough glucose in the urine, so you cannot lower the glucose significantly. So from the glycemic point of view, one should not be using SGLT2 inhibitors below certain cutoffs, maybe for dapagliflozin below 45 or so, for others maybe even at a slightly lower level also. But what has been shown is the other benefits, the cardiorenal benefits pertain even at lower levels, even below GFR of 45. But the study trials have generally shown efficacy up to about 25 milliliter, let us say. So below that, one doesn't have the evidence to say it is still effective. But general recommendations are, though you do not initiate at eGFRs below 25 or thereabouts, but if someone is on an SGLT2 inhibitor and is otherwise not having any problems, one may continue down to even the stage of renal replacement therapy. That's the current recommendation.
I think great answer. Subhankar, recently I saw one invitation where people want to combine SGLT2 with the Finrenon, and maybe that's something which is being brooming behind us, and you may be listening about it soon. I think there is a question by Dr. Vishi Murli Krishna Raj. It is said that DAPA plus SITA combination has lower incidence of UTI, as just now Sasank alluded to.
Yes.
Murli,
Yeah.
absolutely correct. And the other question is it not too early to bat for DAPA exclusively? What has happened with all drugs when introduced? If you bat whether they will sustain or not. Now, before coming for that, I have only two important things to remind our esteemed audience. I have got about another 5 to 10 minutes. Now, let us go through quickly. I will ask three of you. About the DAPA's unique benefit. Only 3 or 4 sentences about DAPA HF. We like to speak about it. Can I even ask you, DAPA HF? What do you think about DAPA HF?
So obviously, the great.
To make a long story short, do you believe that DAPA HF, whether paid for ref, DAPA has definitely shown great benefit. Numbers will not.
Yeah, absolutely. I mean, so all the trials, DAPA HF shows that there's increased benefit in terms of cardiovascular death from cardiovascular causes and heart failure. So there's no doubt that there is a large body of heart failure that is probably undiagnosed in the type 2 diabetes population. And definitely using dapagliflozin in that kind of context gives us additional benefits.
Absolutely. And you did allude to NASH. And the other drugs which have been suggested for NASH is possibly GLP-1 RA, which is only one oral is available. And Subhankar, what do you think about the role of DAPA about the NASH, which is one of the burning issues in front of us?
Yes, at this point of time, there is some evidence, but I don't think it's
we need a clinical trial.
Sort of proven itself. Proven itself to be used as primary treatment. But there could be some spin-off benefits in this context also.
Okay, I think good. I think, Sasank, I'll ask you the issue regarding DAPA kidney, the DAPA kidney trial, DAPA kidney study, why it was stopped early, and what are the take-home messages in your own language, not the percentage and all that.
DAPA kidney, I'll be quick and succinct, clearly showed compelling benefits. So the Data Safety Monitoring Board felt that the placebo group cannot be left untreated. It's unethical to leave them untreated. And therefore, the trial was prematurely terminated because it's a clear nephroprotective agent. So our nephrologists now have an option both in the diabetes space and in the non-diabetes space, an agent beyond ACE and ARB, which is nephroprotective, both in the space of microalbuminuria and eGFR slope reduction. So clearly we have compelling data that we have an inbuilt molecule, which is a glucose molecule, which is a cardiovascular molecule and a renal molecule. And DAPA CKD trial, which was prematurely terminated, or the DAPA renal trial, clearly showed that the renal benefit is compelling. The need for renal replacement therapy, the need for people going on dialysis. So if you want to hit hard, hit early and save and salvage the kidney, DAPA kidney trial clearly separates out the boys from the men or the girls from the women. So I think that's the differentiator.
Fantastic.
In a very simplistic way, compelling data, renal molecule, cardiac molecule, diabetes molecule, endocrine molecule, pleiotropy, just like what statins did to cardiology with pleiotropy, with stabilization of the plaque. I feel SGLT2 inhibitors and maybe with proven cardiovascular benefit, which DAPA has, is doing into the field of endocrinology, diabetology, cardiology, and nephrology.
I think it is a great revelation that in today's world, DAPA is the glyphogen, which is easily available to all of us, affordable to all of us, and it has great benefit on the heart failure data. It has a great benefit on both types of heart failure, reduce the precipitation fraction. It has a data to show that it is kidney friendly. So I think the question of combining it with either sita or metformin is absolutely above board and a very welcome combination. Now I will ask a very important question here. Now somebody has asked that Dr. Major Devashish Shah from Calcutta must be in metformin intolerant patients. It is a side question. That is not the main thing we're discussing. Theme we're discussing today. He says that in metformin intolerant patients, what is the place of low dose PIO? I think low dose is PIO is 7.5, but I think lower than that we don't give. So he's asking, what is low dose PIO place? Sumankarta?
I still feel there is pioglitazone is underutilized, especially after the ban in our country and also the hue and cry across the globe. However, I personally do not have any experience with low dose pioglitazone, meaning below 15 milligram. I don't have experience, but it can be a good alternative provided we know the limitations of pioglitazone in terms of its fluid retaining property, weight gain property, and because of fluid retention, worsening of heart failure, those issues are there. And beyond that, especially in elderly women, the bone risks, the fracture risks that are clearly increased with the use of pioglitazone. But beyond that, definitely pioglitazone has a place.
Absolutely. Dear friends,
We have some
before
experience in low
yeah,
dose
yes,
bio. We
Shashank, please,
published the paper,
Shashank, please come in. Please come
Dr.
in.
Yeah,
Das,
yeah,
on
yeah,
7.5,
I know.
15, and 30,
Dr.
which we
Panikar
published
and
in
yeah,
Dr. Panikar and myself. And we
yeah,
do have
yeah.
some data on that. But I think beyond that, what Shubhankar Rai said very clearly, the bone risk and this thing. But there is one advantage with the advent of SGLT2 inhibitor. SGLT2 inhibitor offsets that unmasking of cardiac failure, which a PIO will do. So if you use low dose PIO with a DAPA in a particular phenotype, which is severely insulin resistant, there might be some synergistic benefits. But as I said, this is a situation of metformin intolerance, which does occur in 1 in 10 to 1 in 20 population. And then you need to individualize. There again, a SITA-DAPA combination is a reasonable choice. You have a lot of other evidence-based options available with you. And I agree with Dada that the bio is underutilized in our country, which is highly insulin resistant. But you need to be careful in your selection, in your use, and maybe there is some synergy with the advent of SGLT2 inhibitors of offsetting that fluid retention property of a glitazone.
I think, dear friends, before we close, I would like to all of you to give your very brief comment. What we have discussed today's evening is a very simple thing. Giving a combination of metformin, which is still in our place, in our views, the number one. We call it exchangeably with number one with SGLT2. Number two, in our country, metformin has a maximum use from 1950s, where the Americans started using 1993. So this is our own drug of metformin, and that remains the number one drug. If you want to combine it with DAPA instead of SU, or I mean, in some people also you will need DAPA plus SU, but majority of patient DAPA plus metformin has stood out a very important combination, which is the actions are very clear, the benefits are very clear across the board. I will not repeat for the interest of time, but it's a global 360-degree approach. And we know metformin has been hailed as the molecule of the decade. So this combination, and also working little further, the combination of dapagliflozin plus a gliptin, and here sitagliptin, which has undergone the maximum CBOT trial, or the only one which have undergone CBOT trial, this makes the thing absolutely clear. So, dear friends, before we close, I have to take the opinion of all the three experts. Now, I will tell you this much, that early intensive control is the order of the day. Single drug use has to be replaced possibly by double drug use. And in today's scenario, both the combinations that we are talking this evening has a great message for our clinicians. The drugs do not work if you don't prescribe them. We have in the armamentarium the drugs, which are very useful combination. And as Shashank pointed out, when we combine these drugs in FDC, the cost comes down, the compliance increases, convenience increases, and it is available at a lower cost than what we get by individual drugs. And we have experience using both the drugs, whether it is DAPA plus MET and or the DAPA plus leptin. Dear friends, today's scenario, when we have that early aggressive control as the target, not to use a two double drug combination therapy, which is available plenty, very affordable, is not acceptable. I will like to close with the opinion from first from Jiban, then from Shashank, and last from Shubhakata. Jiban, your closing remarks and the take homes.
Yeah, I think in a country like India with a huge population of diabetes, the fact that we have a game changer like dapagliflozin available at a reasonable cost to the Indian purse is a really huge benefit. And as you correctly pointed out, sir, that it doesn't have benefit unless we prescribe it. And if you can use a synergistic combination at a very reasonable price to get good glycemic control early, we should hit hard, hit fast, and hit early.
Fantastic. Shashank?
So Jeevan took words out of my mouth. I echo exactly what he said. You know, create, if you reduce the glycemic burden in the first decade of a diabetic's life with hit hard, hit early policy, what we are going to do is we are going to move towards a complication-free India with people living with diabetes. And our goal should be that if you want to get to goal, not just on the glucocentric model, but with weight, with cardiovascular risk factors, and with cardiorenal benefits, the quadrant, the big four as they call it, I think these evidence-based combinations, which are affordable, accessible, available, and appropriate, if used appropriately, correctly, early, at a cost-effective option, will keep people living with diabetes complication-free and also make them live longer. So it's important that there is a mortality benefit, there is a morbidity benefit, there is a complication benefit, and eventually we are here to serve our people living with diabetes to keep them complication free. And I think we have options available to us which are affordable and accessible. So thank you so much.
Thank you. Thank you, Shashank. There are two very intelligent questions. I wanted to close with Subhankarda, but two very intelligent questions. Number one is from Dr. Vasant Kumar. Amongst all the gliptins, which one is the most dependable and with least side effect to combine with DAPA? We're discussing about CETA today, and maybe we can have the opinion of the house, but I must tell you, the CETA is the only gliptin which has seen the CBOT trial introduced across the globe, both sides of the Atlantic. Some gliptins are not introduced in the other countries. Some gliptins have not been able to bring down the price. So I think in today's scenario, it is a good gliptin to combine with. The other thing is that Dr. Bipul Kumar Ghosh, Shashank, the question is to you, because you are the lowest BMI amongst all of us. Whether, not you, Shashank, I'm just telling, the question is among whether 5 milligram DAPA can be used in low body weight. You can tell the differential between the body mass index and the lean body mass and the visceral versus general obesity and the use of dapagliflozin at a lower dose in such patients. Shashank, very quick and very brief answer, please.
I think we are thin fat Indians. So even if we may have a lower BMI, we still have a higher body fat composition. So I think sometimes even if you have a BMI of 22, 23, 24, metformin will still work. It doesn't mean that you don't need to use metformin. And similarly, some of these other agents may still work, but you may need to down titrate the dosing of it. So dosing is individualized. And again, as I said, we need to individualize some of these therapies. But we are thin fat Indians. So look at the body fat composition and not just a BMI. In fact, BMI as a yardstick in the Indian population is a very poor marker for obesity.
Absolutely. I think Vipul, you have got the answer. Thank you very much. The last word from Professor Dr. Subhankar Chaudhary, Subhankarda, our dear Subhankarda.
I fully echo the sentiments or whatever the facts that have been expressed by Jeevan and Dr. Shashank. But I, maybe because I'm the last word now, maybe I wish to play the devil's advocate. So I wish to put in the words of caution. And I would hark back to Shashank's statement that we need to individualize. So just because we have got effective combination doesn't mean that we do not have to follow up those individuals. We have to. And also, there is a small but definite risk of euglycemic ketoacidosis with the use of the SGLT2 inhibitors, and especially if we are going to push them in grossly insulinopenic patients, we may not be doing them any benefit, maybe doing them harm. So let us follow the standard guidelines, let us individualize, let us also follow up our patients, whatever we treat. Just because this gives so many advantages, protects the heart, the kidney. So just we cannot close our eyes, prescribe a drug and say goodbye. So we need to follow up. So with this, I would like to thank all of you, especially Professor Das, and also the co-panelists, and of course the micro people for getting this act together. Thank you very much. I enjoyed.
Thank you, Subhankar. Thank you, Sasank. Just stay back for because Seshagiri Sahib is here to give his gratitude and love. Now I must tell you that both these combinations, DAPA and SITA, DAPA and MET, have come to stay of great benefit in Indian patients. Should be prescribed for early intensive control, which is the order of the day. Of course, one cannot forget the word of caution which Subhankar gave, but those cases are clear as daylight. We must customize. We must treat everybody as their diabetes, their body weight. I know the we have got that as the circle as their body demands. With this, I must tell you that is 8:14. I have got 1 minute, and I will now request the Seshagiri Sahib to kindly give his vote of thanks, and then we'll close.
Thank you, sir. In fact, I think the all the delegates who have joined would have had a very interesting and thought-provoking session. And also, I would like to state that more than 1,000 doctors from across the country have joined this
Very good.
session. And I'm
Very
sure all of them would have enjoyed the discussion this weekend. And I would also like to thank Dr. A.K. Das, sir, who has joined us as soon as we asked for this program. And also Dr. Seshank, sir, and Dr. Subhankar,
Great.
sir, and also Dr. Jeevan for making this program a big success. Thank you very much once again.
Thank you.
Thank
Thank
you
you,
all.
Shankar. Thank you, Sasank. Thank you, Jiban.
Thank you.
And thank you to
Thank you.
Microlab for organizing this. It is small and sweet program, short and sweet program. We started at 8:05, 8:05, finished at 9:14, 9:15. Thank you very much. Bye bye. Bye bye.
Thank
Thank
you.
you.
Very good
Night.
night.
Thank you.
Thank you.
We love you, Professor Das. You are most sweetest diabetologist in India today. And thank you, Sheshgiri, and thank you, Shubhankar and Jeevan.
Thank you all. Thank you.
Thank you.
And thank you, Michael.
Thank you. Satish, thank you.
Thank you. Thank you.
Thank you. Bye bye. So we'll leave now. Sasagiri, thank you.
Yes, sir. Thank you, sir. Thank you very much.
Thank you. Bye bye, Subhankar. Again, Sasank and Jiban and Satish and of course Sasagiri. Thank you. Bye.